I'm Maureen Bizignano, as you met me this morning, and we've got a wonderful session. The honesty and the transparency that you're going to learn about this afternoon is really going to help you to accelerate your improvement projects when you get back at home. This group has worked through issues that they want to talk to you about so that you can learn to accept failures and actually build on them, because the quicker you get through the failures, the more you understand the causes of the failures, the faster you can accelerate the improvements that you're working on and the spread across complex systems where the cultures are going to be different in every place. So we're going to have two presenters talk about the importance of relationships in driving improvement, and then we're going to have a lot of people who've been working in improvement projects over these years describe very clearly for you how you can take back some tools to accelerate the pace of improvement. So welcome to the F word, and I'll turn it over to John Boulton.
Thank you, Maureen. Good afternoon, everybody. My name is John Boulton. I'm currently the Director of Quality Improvement Patient Safety at Public Health Wales and the Director of 1,000 Lives Improvement. For some of you who may have seen me at other points in the last 2 days, contrary to popular belief, I do actually have a day job and I don't just play with Lego. So I want to introduce my other presenter. When we were talking about this session, it's one of those sessions that we had over coffee, or it might have been a glass of wine. And when we talked about it, it sounded like a really great session to actually put into the forum. Stood in front of about 600 or 700 people. It's quite daunting. So, Barbara, do you want to introduce yourself?
I'm Barbara Grey, and I work at the South London Maudsley Mental Health Trust, and I lead the Change Coaching and Quality Improvement team. And I have here today some people from the South London and Maudsley who are going to be responding to some of the learning that we've made around failure. So we've got Michael Holland, who's the medical director, and we have Sarah Cornick, who's a consultant psychiatrist, and Faisal Sethi, who's a consultant psychiatrist and a service director. And we have Rob Harland, who's a clinical director, Sasha Passot, who's a quality improvement lead, and Sabrina, oh my goodness me, I've gone completely blank. Sabrina Phillips, I beg your pardon, Sabrina, failure, who is our head of nursing for one of the adult mental health boroughs in the trust. So we are going to talk about celebrating successes in learning from the failures that we've made. And John and I are going to talk about from an individual perspective, about what we've learnt from our relationship in working together through helping the trust develop its quality improvement capability. We're then going to talk about it from the team perspective, particularly from the quality improvement team and its learning, in how we have worked and grown in our ability to help the organisation. And we're going to look at it from the trust and the wider system in terms of the learning that we've made. So, hands up, how many of you feel embarrassed when you fail? Okay. How many of you get anxious when you fail? How many of you feel liberated when you fail? Ooh, not many. How many of you feel creative when you fail? A few more. And lastly, how many of you feel a bit uncomfortable and positive when you fail? Good, okay. So we're going to play for you a short video, because some of the words that people describe to us in our work supporting them making improvement is they feel blamed and they feel people are saying it's their fault. So what you'll see from this video is that it's not a helpful concept. So in order to be really creative and learn from failure, we need to think and behave differently. So we're going to show you Brené Brown's very short 3-minute video about blame.
How many of you are blamers? How many of you, when something goes wrong, the first thing you want to know is whose fault it is? Hi, my name is Brené. I'm a blamer. I'll just tell you this quick story. So this was a couple years ago when I first realized the magnitude to which I blame. I'm in my house, I'm on white slacks and a pink sweater set, and I'm drinking a cup of coffee in my kitchen. It's a full cup of coffee. I drop it on the tile floor. It goes into a million pieces, splashes up all over me. And a millisecond after it hit the floor, right out of my mouth is this: "Damn you, Steve." Who's my husband? Because let me tell you how fast this works for me. So Steve plays water polo with a group of friends, and the night before he went to go play water polo. And I said, hey, make sure you come back at 10, because you can never fall asleep until you're home. And he got back like at 10:30. And so I went to bed a little bit later than I thought. Ergo, my second cup of coffee that I probably would not be having had he come home when we discussed. Therefore, and so the rest of the story is I'm cleaning up the kitchen. Steve calls, caller ID. I'm like, hey. He's like, hey, what's going on, babe? What's going on? So I'll tell you exactly what's going on. I'm cleaning up the coffee that's spilled all like dial tone. Because he knows. How many of you go to that place when something bad happens, the first thing you want to know is whose fault is it? I'd rather it be my fault than no one's fault. Because why? Because it gives us some semblance of control. But here, if you enjoy blaming, this is where you should stick your fingers in your ear and do the no thing, because I'm getting ready to ruin it for you. Because here's what we know from the research. Blame is simply the discharging of discomfort and pain. It has an inverse relationship with accountability. Accountability, by definition, is a vulnerable process. It means me calling you and saying, hey, my feelings were really hurt about this, and talking. It's not blaming. Blaming is simply a way that we discharge anger. People who blame a lot seldom have the tenacity and grit to actually hold people accountable, because we expend all of our energy raging for 15 seconds and figuring out whose fault something is. And blaming is very corrosive in relationships, and it's one of the reasons we miss our opportunities for empathy. Because when something happens and we're hearing the story, we're not really listening. We're in the place where I was, making the connections as quickly as we can about whose fault something was.
So, one of the things that I think Barbara and I would reflect as we've been doing this presentation, preparing this presentation, this has been one of the toughest presentations I think either of us have ever done, because we've actually spent a lot of time reflecting and starting to understand what failure means from our perspective, and just how uncomfortable it is to stand up in a room and be very, very open and very honest. Now, many of you will have read Jim Collins' book, Good to Great. It's one of the first books that I read when I got really interested in improvement and thinking about leadership. But one of the things that's very interesting when you actually look through the management literature is how many of those books, that if you go to the bookshelves within Waterstones or any of the other bookstores, is how many of those books about management are celebrating the success of role models, of people who we're all trying to model in our daily work. Now, is that any different as we're starting to think about quality improvement? We've been at what is a fantastic conference over the last 2 days, and we've seen some truly amazing work. But within that, how much time have we actually spent actually thinking about the things that didn't work? So we're potentially missing an opportunity by just having this one-sided focus on success. So what happened, what went wrong, what could we do differently next time? But the interesting thing is and all of you who teach improvement, who train improvement, or who've been taught will have seen this slide before. Learning from failure. So the example of Thomas Edison, when he was quoted, "I've not failed, I've just found 10,000 ways not to create a light bulb." Or WD-40. So the reason why it was called WD-40, because they failed on the first 39 attempts. So we use this in our teachings, but then we never then move to the next stage and actually ask the question, well, how do we really truly learn, and what does it feel like to actually be in that discomfort zone? Here's one of the challenges, is failure is not an option from an early age. You're taught at school that being wrong is a bad thing, and it's not an opportunity to learn. We lose that very early in our learning as children. But the other thing as well is we then have this individual. Does everybody know who he is? Silence in the room. So this is Frederick Winslow Taylor. You will all have heard of him. In 2019, he's fairly derided as somebody who was very critical of the frontline worker. But actually think back to the early 20th century when he wrote the book on principles of scientific management. He wrote the book on how to build a factory. And at that point, he was not a genius, and he should still be celebrated for the great work he did at that point. But now people are starting to see that his scientific management has got flaws. So his first flaw, that he believed that management control was a necessary precondition for increasing productivity. The next one, he thought that all processes could be optimized. He had a very narrow view of improvements, and then it starts to get worse. Only one defect is possible, and that cause is people. If only those damn humans worked harder, if they worked in the way that I'm asking them to, everything would be fine. That they failed to recognize systems and communities as organizations, and they viewed workers as machines. So when things went wrong, and things go wrong in a Taylorist world, we blame the workers, exactly the way that Brené Brown actually described. So these are described as flaws, but I'm going to call them principles, because in the 80s and the 90s, healthcare fell in love with Taylor. So we sit in organizations that use these principles on a daily basis, and we wonder why we don't actually want to discuss failure, because it is our fault. So I want to talk to you about a personal failure, and when I did this is really uncomfortable. I opened the slides last night and looked at this presentation that I did over 10 years ago to my colleagues when I was a practicing rheumatologist. And I'm very ashamed of the presentation. I can safely say 10 years on, I would never deliver this presentation in any way, shape or form like I did. But I was being asked to actually support transformation of an outpatient program in the hospital trust I worked in. And I was told how to do it, and I was asked to increase productivity, and I needed to make my colleagues work harder. So I got a load of data. I did a long presentation. We talked about lean, we did some games, and then I put this slide up. And if you can understand this slide in the next 20 seconds, you're a much more brighter individual than I am, because I'm really struggling to understand what I was actually trying to tell them. But what I'd somehow worked out is how much time they all had in clinic, and I worked out how many people they all saw, and I calculated this and multiplied it by this, put it into a nice chart, and came up with this nice column graph. So each of those columns is an individual physician or an individual consultant, and this was 2008, 2009. And we can see some variations. Somebody's working a bit harder, somebody's working less hard. And just to add insult to injury, I added in the next year. Now, when I put in the next year, it's fair to say all hell broke loose in the room. So you'll see that colleague number 2 working at about 50%. That was my clinical director, and she said to me immediately afterwards, "If you ever do that again, I'll ruin your career." It's a fair point. A couple of the other colleagues were so mortified they never spoke to me again for the next 2 years. 10 years on, that still haunts me, and I'm very, very fearful about presenting data in this way when I'm presenting to anybody. And anybody who's worked with me over the last several years will know how keen I am that data is not data for judgment, it's data for learning, and it's data for improvement. But it got worse because I'd just read Deming's books, and so I thought I should start speaking like Deming. So I put this up. As if I'm like Deming, quality must pervade, at which point my colleague stood up and walked out of the room. It's very difficult, I know people are sort of giggling and laughing, it's very difficult to stand in front of you, and actually it's still making me uncomfortable actually discussing it at this point. So 10 years on, I would describe myself as a student of this man, W. Edwards Deming. And he's given me a really fantastic quote and some fantastic learning from what I did all those years ago. I crushed my colleagues by the way that I was trying to manage them. I would never ever do that again, or so I hoped. So, 10 years ago, I'd read his book, I thought I understood profound knowledge, and there's me thinking, oh, I really appreciate the system, doing some fantastic psychology of change with my colleagues here. I've got some really great knowledge of the outpatient system because I can get data, and I've got some variation. 10 years on, I'm not even sure that I understood variation at that point. I certainly didn't understand psychology of change and how I'd bring people on board. I had no appreciation whatsoever of my colleagues' systems because they were all different. We all saw very different patients. And I certainly had no knowledge at that point of my other colleagues. So one of the things that I'd really like to get across to you at this point is learning from our failures provides a really neglected source of rich learning that we can actually enhance the way that we actually go forward and do our work in the future. Now, to quote Michael Jordan, I've failed over and over and over again in my life, but now 10 years on, I think I can probably very proudly say I have been successful. I work with a fantastic team in 1,000 Lives. I lead a national improvement team, but it doesn't mean to say that I don't continue to fail almost every day or every week. So, Barbara.
So, we had the privilege and were very excited about John and his colleagues coming in to work with us in the Trust to help us develop our capacity and capability for our improvement journey, which we started 3 years ago. And when you came in, you didn't understand our system.
I'm not sure you actually helped me understand it.
Absolutely.
So, just to give you an example, Barbara, is I can remember coming to the learning session, I did a very personal story. I told you a story about a car crash that myself and my family had in Doha. My son nearly died and my wife was taken to hospital with a suspected spinal fracture. And it went down like a lead balloon.
You didn't have any appreciation of the immense knowledge and skill that we brought to the table around psychology of change, particularly coming from a mental health trust. And we lost sight of what we brought to the table.
But I was here to coach you.
Okay. We also had some understanding, immense understanding of clinical knowledge and of organisational theory and change.
But you didn't understand improvement.
So we went through a bit of a seesaw. So when you came to help us with our first large-scale initiative, which was our first really ambitious piece of quality improvement across the whole of adult mental health services, involving 2,800 staff and lots and lots and lots of service users and carers, when you came in, the team felt we were here and that you were here.
That's not how I felt the next day.
No, I know it wasn't. And then in September, when you came back for the second learning event, as we were planning the second learning event, to overcompensate for how we were feeling at the beginning, we decided that we would prove to you that we were capable and knowledgeable and brilliant facilitators.
And you didn't let me speak.
I certainly didn't.
So Barbara, how did we get to this?
I think that what you and I have done in quite a brave and courageous way was, one, acknowledge what we both didn't do particularly well, and that putting together the jigsaw of the profound knowledge, system of profound knowledge, that we both brought as organisations different things to that. And I think that had we not had that conversation early on about the failure in the relationship, it would have been really irresponsible.
So I think that the two of us were very brave. We had a very difficult conversation one day in November when I'd been asked to go over and do some work with QIT. And I can remember getting on the train in Bristol and being really anxious.
And we were sitting in Marina House feeling really excited that you were coming. And so there's something about how we check out assumptions with one another, and that it's okay to get things wrong. And talking about it today still feels uncomfortable.
So one of the things that we have done is that we've got to this, where actually that jigsaw puzzle has come together as a team, and actually we are starting to see some success in the way that we're working together as a team. And between Barbara and I and the QI team we've really managed to support the QI team in their fantastic work that they support. And we've managed to build some of the capability programs within your organisation. Now, I came at my improvement science with a real strong focus on data. And one of the things that I've really learned and I've really appreciated learning over the last 3 years is how little I knew about the psychology of change. And I'm very grateful for the work that I've done with Barbara, because it's really shifted and changed the way that I think about improvement.
And equally, I have learnt an immense amount about understanding variation, which I feel was missing from a lot of our work, which has been very, very exciting, to the extent that we now have many, many more people in the organisation, from healthcare assistants to business managers to senior clinical staff, feeling much, much more comfortable with using their data to help them with their improvements. So I think that when small failures are not widely identified, discussed and analysed, it's difficult for larger failures to be prevented. And so I do think that had we not had those conversations, it would have been very irresponsible on our part. So I want to move on to talk a little bit about the team. So when the team first set up, we had a bit of a bumpy start. And as the leader of the improvement team, I had to make some very, very difficult decisions. And the team didn't feel particularly safe. And it's something that we've worked on really hard over the last 3 years. So what we used was Amy Edmondson's framework for developing psychological safety. And we know that the more psychologically safe you feel, and together with the more motivated and focused you are on objectives, the more likely you are to be able to work effectively. So there are 4 quadrants to the psychological safety. As a team, we've never had time to get into the comfort zone, and we've not been in the apathy zone. We did spend a fair amount of time in the anxiety zone, so there was a lot of pressure on the QI team to help the organisation make improvements at speed. And we were really keen to succeed. And in our efforts to succeed, sometimes it was actually quite difficult to have the courage to say, can we stop this, because this isn't working. And so we went on sometimes for too long before we actually drew breath and thought about it. So now we're working more in the learning zone, which is not a soft option. It's really hard work and it requires the support of the organisation. And I was thinking back to the keynote speech yesterday morning, where it talked about the importance of having organisational support. And unless you've got that, it's really, really difficult. So we know as a team, we're not perfect, we get things wrong, but we're in a much better place than we were 3 years ago. And because the team's in a better place, we are more able to help the clinical teams that we're working with be more able as well in their improvement efforts, together with service users and carers.
So this is fantastic. So Barbara and I are now good friends. We gave each other a hug yesterday, which is very different to 3 years ago. We've got a QI team which is functioning, and it's fantastic when we have QI teams that are starting to function. And then we have this, so we start now talking about spread and scale up. And it's one of the things that I'm constantly asked in Wales. John, what are you doing about spread and scale up? And it's like, well, actually you don't really need to do much. If we believe what Gladwell's saying about ideas, products and messages and behaviours spread just like viruses do, it'll just go. We need a nice QI team, we need some good teamwork, we need some leadership and some love, and we need to understand failure. And then this will all happen. So how many of you have actually seen this in an organisation when we actually do change? Not seeing that many hands, so I'm assuming that actually it's fairly infrequent. Now, why doesn't it spread like a virus? And actually, if we want to understand why it doesn't spread like a virus, maybe we need to think of it from a failure perspective. You take the Health Foundation report on the Spread Challenge 2019, the IHI have done a lot of work on spread before, and we're still struggling with it. So in Wales, we've been very open and honest about some of the work that we've learned from. Unfortunately, the Health Foundation don't have this paper at the conference, but it's on their website, and I would say that this is a very open, honest and very frank account of learning about how not to do a large-scale improvement programme when we were thinking about patient flow in Wales. Now, some of the Welsh contingent in the room might feel uncomfortable that I'm stood up and actually saying that this is a good example of learning from failure. It is, and it's really important. So these are some of the comments that actually they took from that paper. So mismatch between the ambitions and its design, its timescale, etc. Significant variation in engagement and leadership support across the health boards. And many of the projects not clearly aligned with the strategic objectives. This is a guidebook on failure, and it's really worth a read, and I really recommend that you actually read it. So 1,000 Lives as a team are currently going through a strategic refresh, and we've used this as a real learning exercise to understand not just the fantastic work that they've done and what they did and how they did it, but what we didn't do and what we didn't get right, and how we do think about learning from spread and scale up. And you've all seen this. We all teach it as we're actually doing improvement, the diffusion of innovation curve. And the theory is that we work with the innovators, we work with the early adopters, and if we work with those, we hit the tipping point and everything goes. That's the theory. If you actually start to look in the literature, it's a little bit more complex than that. There's a bit of a problem with the innovators and the early adopters, and there's a bit of a problem with the early majority and the others. So the innovators like things that are rare. So they'll be there at midnight, outside the Apple store to get the next iPhone. The early adopters would be very similar, so they like things that are scarce. They want things that others can't have. Over on the other side, the early majority don't want things that are rare, they want things that people are talking about. And they want what their peers are talking about, not what the innovators and the early adopters are talking about. And so here's the problem. As soon as the early adopters start sharing with all of those on the right-hand side of the curve, it ceases to be rare. So why would we actually start thinking and seeing spread if we're thinking it in that way? So this is what we're seeing now, and people are starting to describe these chasms. Now I'm seeing these chasms of failures in the way that we actually think about scaling improvement work. Within the literature, we see this chasm at about 15%, and most of it is about the way we actually communicate within that organisation or within that improvement programme, moving from this is scarce, it's rare, it's really exciting, do you want to be part of it, to We're all doing it. Why aren't you part of it? It's subtle, but it's a change in the way that we actually communicate. But we don't always do that, and there's a lot of learning from the programs that we've been through in the literature that is suggesting that this is the case. We think there's a second chasm. Trouble with innovators is if you lock them in a room, you turn off all of the lights, they'll find a way of innovating and getting themselves out because they just keep doing it. And they move on, and they don't share their learning because they've found the next big idea. And so there's a gap between the innovators and the early adopters. The early adopters are viewed as visionaries, but they're impatient. And what they want is the information. And we fail, and I'm sorry, forgive me if you disagree with this, I think in improvement, we fail to get the data out from the innovators into the visionaries and then start thinking about how we change the communication in scaling up. So in thinking about that failure, what are the things that actually we could overcome? So if we think about chasm 1, it's creativity. It's improvement science. It's measurement, but measurement in a way that engages with those early adopters. It's that communication style. Thinking about things that are rare, thinking about things that are exciting, and it's psychological safety. Making it safe for people to actually test things and design things and actually not blame them when things actually go wrong or whether they fail. And it's about leadership. So what's the style of leadership that we might be thinking about here? This is about enablement. I'm enabling you to do some improvement. I know that there'll be some failures along the way, but this is what we actually need to do. And it's about co-producing, and it's about co-producing with our staff as leaders, and it's about co-producing with our patients. So is it the same for chasm 2? Well, in our work, we think that that's different. It's leadership again, but it might not be the same style of leadership now. So it's not about enablement. We're now at a point where we're making a decision that actually we're going to take a risk as leaders and we're going to scale. And so this leadership style is, we're doing this, how do I help you? It changes. And it's this learning as we're starting to think about scaling that we may think about doing things differently. So it's improvement science, but it's not just PDSA, and it's not just a little bit of Deming. It's about thinking about building breakthrough series methodologies and other collaborative style methodologies to enable that spread. It's measurement, but it might be in a slightly different way to the previous way we did it. And it's communications. And as I said, this isn't about it now being rare and exciting. This is about everybody's doing it. It's a subtle change, but those subtle changes probably make the difference in the way that we think about improvement at scale. And again, it's co-production, and probably one of the most important things is about celebrating success.
So we, as I said earlier, had a very ambitious programme of work to help improve adult mental health services, and there were 3 core streams of work. One was around improving safety, one was around improving flow, and one was improving the best standards of practice. So whichever borough you lived in, and we have 4 geographical boroughs, as a patient you could expect the same standard of care. So we thought, brilliant, we'll get everybody in a room together and we'll sort this out and we'll carry it through and it'll be fine. And it failed. So initially we didn't have some of the right people in the room, we didn't have some of the right leadership approaches, and we didn't have a good enough data system and communication. Now, fortunately for us, last summer there was a big restructuring within the system. So we took the whole of adult mental health and we put it back into boroughs and established leadership teams for each borough. And as a QI team, we've noticed a massive change, particularly over the last 3 to 4 months. So we've got much better leadership engagement. We have continued with the improvement and engagement with service users and carers who have co-produced all the improvements that we're doing. We've got a much better data system developing, which we've called Deming, and a much better communication methodology. And it's taken quite a lot of humility from all of us in different work roles to acknowledge the fact that what we started out with wasn't working. And one of the big changes I've noticed, which is an improvement, is that each of the borough directorates have weekly leadership huddles, and they invite teams to come along. And those huddles are now being developed in local teams too. And so by taking it in a different way and enabling the system in a local level, we're developing mini collaboratives where people can work within the gift of their local services and then come together. And it's taken an immense amount of effort. It's been really hard work and quite brutal, it's felt at times, to actually say this isn't working and what are we going to do differently. So we're still making some mistakes, but we have learnt a lot about how not to do large-scale improvement work and that you actually can't achieve it in 18 months. And so I think we're on a much better trajectory now. So what we're going to do is we're going to hear from some of our colleagues now before we have a final slide with some really key points for you to take away.
First of all, thank you, John and Barbara, for being so honest. I think the story, your own personal story about the different perspectives that you brought to improvement projects and how it's not easy to bring those together is really a very powerful one. And what you also heard from Barbara is that various people in the organization, different parts of the system, have different perspectives about the kind of challenges that we're trying to meet here. So we wanted to have you hear from different roles in an organization, different pieces of the team, to talk about what their perspectives were on failure, what they learned, and perhaps give you some one PDSA to take home. So we'll look at lessons learned, and I'd love for you to start with, down at this end, with what have you learned from failure?
One of the projects that we did in Southwark was trying to implement red to green. Basically, that's a system looking at how each day in an inpatient ward added value to that patient's journey, i.e. getting them closer to home. As a leadership team, we'd set a date that we were going to implement it in all our teams. What we hadn't done was made sure that we had the leadership teams in place on our wards. So what we've learned is, as a leadership team, i.e. the exec for the borough, we need to ensure we've got support in our ward teams from the team leader as well as the consultant, who will bring the team along with them to ensure that we can implement this. And we've been doing that now, and we're going with people that want to do it, and we're testing it small and looking at spreading it as we learn as we go.
So you would use the diffusion curve and start with the willing.
Yes, definitely. So that's what we're doing this time around.
And how would you engage the leaders differently up front?
So what we did as the exec team was go and meet face to face with the consultant and team leader together, put the proposal across and found out from them were they ready to do it, and where staff were ready to do it, we went with that. So that's worked better this time.
Great, thank you very much.
So as Barbara mentioned, my name is Sasha and I'm one of the quality improvement leads at SLAM, and one of my work streams is based around safety, and that's reducing violence and aggression. Now, we had this trust-wide project a few years ago that we wanted to implement across the whole trust. Now, that's a prime example of failure because we didn't learn from scaling up and spread initially. So we went across to all of the services using all of the interventions that we thought was going to work based on what our pilot study was telling us, but it didn't, because evidently every single ward is different, every single service is different in their policies and procedures, and one of the learning from that was about small tests of change. So even though you're starting small in your pilot study, when you're scaling up and spreading, you still need to be testing one intervention at a time, one ward, one patient, just so that you're seeing the interventions successful first before scaling up and spreading. Another key thing that we've learned is about internal support. So as a QI team, we would go out onto the wards and we would support them. But what about the teams who are actually doing the work themselves? They need to be taking ownership. The leaders in the services need to be taking ownership, and that's something that we didn't have initially before. It was us going out onto the wards and providing that support, whereas it should just come from the leaders internally. Another example is about just constantly reviewing the work. If you're testing something, you want to just bring it up in a team meeting or a huddle, just to make sure that you're having those conversations about, has it worked, has it not worked? If it hasn't worked, what do we need to do differently? And by doing that, you're constantly keeping up the momentum and the engagement and checking up on things. And the key thing for me is about co-production. So initially in the pilot study, we had that co-production there. We had service users and carers involvement. But then when we went to scale out and spread, that kind of diminished. So a key thing is about having service users on board and asking them questions. So how are you being affected as a result of this? Do you think it's helping? Have you noticed the change? So those 4 key factors, in my opinion, is definitely something that I've learned.
That's great. And one of the points that you're making, I don't know if you've read the book Realistic Evaluation by Pawson and Tilley, 2 researchers from England, but they created a little formula that says C plus M equals O. Context plus mechanism equals outcome. You could, I modified their formula to say C plus M plus QI equals O. But context means that every unit you go to is going to have a slightly different culture. And the exact same thing won't work in every unit. You've got to understand the culture. The mechanism might stay the same, but you've got to be culturally sensitive when you roll it out through QI in order to get that. So thank you very much. How about you?
So my name is Rob Harland, I'm a clinical director. It's very interesting hearing it from your perspective, because I think I had the same experience, but from a sort of different end. So as a ward consultant, I think me and my team experienced the safety program was very much being done to us. And as a result, there was great resistance to that. And I think now, I think we're in a slightly different place. And I think I was also responsible as a leader, as it were, doing it to others. And I think now, I think we've got a different sense of relationship. I know that for my part, I've really wanted to try and stand alongside people who are trying to put in place these projects and understand it and really translate it into a language that makes sense on the front line. I mean, many people have made the point, but so that there's a real sense of ownership.
So your sense of leadership has changed. How do you actually roll something out means you're going to have to stand side by side with someone, understand their challenges, the unique challenges of the unit, so that you can modify and guide. Is that the advice you'd give to someone, or? Yes,
I think it's helpful being having clinicians involved in leadership
absolutely.
of all kinds, nurses, doctors, OTs, psychologists, etc., in mental health. But I think there's always a tension, isn't there, because you're holding the needs of the organisation, an improvement strategy, but also knowing what it's like to be a clinician on the front line and feel resistance to these things and feeling, I know best, I've got my system. And I think if you can straddle the two and keep that tension alive in your own mind and sort of authentically come to grips with it, then I think you can really do something special.
Fantastic, thank you. Fasia?
Thank you. I'm Faisal Sethi. I'm a consultant psychiatrist and an operational services director. Just taking that theme a little bit further, my reflection from both ends. First of all, as a consultant psychiatrist, working in quite a closely knit team, the idea of learning small and then making sure you don't have a big failure. It's not just about failure. We have lots of things that go wrong, things that we nearly, sort of near misses that nearly went wrong. So there's all these sort of daily things that you can learn from. What I would say is that the power of multi-professional working and multidisciplinary working over and above just co-production. So some of the most innovative solutions that we've then implemented, so in the field of managing violence and aggression, has come by 4 or 5 different disciplines working together. And I mean, I'm a medic, a doctor. I think doctors train and come through cultures that are not very good at allowing you to learn from errors or putting your hand up and saying, I've made a mistake. And I'm convinced that all the other disciplines are not far off that. So having the power of that team, now taking it to a leadership sort of platform, having that multi-professional leadership team makes a massive difference. So as Barbara described, in our operational directorate, the senior management team is completely multi-professional. And that there's again the power of innovating and coming up with solutions that I alone would never have thought of. So that's
So your leadership team is modeling multi-professional teams, which is really important because even creating a multi-professional team to institute change isn't easy. But if you've got a model there, I think that really does help a lot. Great. How about you?
So just building on the themes that some of my colleagues mentioned, so we were trying to, again, implement red to green in our directorate, the one I work in, which is in Croydon. And we kept going with the same methodology for weeks and weeks and weeks and weeks, with input from the QI team coming in, and kind of looking back at how much progress we've made. Probably after about 3 months, we realised that we'd had almost 100 hours of input from the QI team, but very little change actually on the ward. And I think my learning point is that we didn't take stock early enough and say, actually things aren't working, we need to do things in a different way. Partly because from a leadership team and the QI team, we were really passionate about wanting to do it, but also the team themselves didn't want to admit that things weren't working, and they wanted to keep pushing forward. So no one was in the right position to just stop and say, actually, we need to do things differently.
You know, my experience with that has been that when I was at IHI, every Monday morning we'd have staff meeting, and I would ask staff, does anybody want to share a story? And every story was beautiful. Every story was success. And I would have to go behind the scenes and say, I know you're having trouble with this project. Would you be willing to share that? Because it wasn't natural to stand up in front of your peers and say, this isn't working. And so somehow as leaders, you need to make it okay. I would tell a story and I'd have somebody ready to stand up and tell a story. And that broke the culture through, but it wasn't easy. So I do agree with your sense that if you just, nobody wants to admit it. And so you have to kind of build the systems to do so. Thank you.
So I'm Michael Holland, I'm Medical Director at Southland Maudsley. So the failure that I saw was, in myself particularly, was as a leader in terms of understanding my role and what I needed to model across the services around leadership and around QI. And it was very much around a conversation that I had with Barbara and someone external around actually how has the leadership changed to deliver quality improvement across the organisation, and what QI am I doing at this moment? What's my personal project on QI at this moment in time? And of course I sat there and went, well, I don't really have one. Everyone else is doing it, and actually isn't that the point? And actually the realisation, the question being, why do I expect everyone else to change but not me?
Wow.
And actually I had to reflect, and it took quite a long time, a while to think about that one, before actually taking on the QI project that I have to now drive. That's my QI project that we have to change and bring about improvement. It's for me to lead and deliver, because all the problems that I face doing QI in the organisation are exactly the same problems that every other individual within the organisation faces doing QI. Where do we get data from? How do I have the time to do QI? I'm too busy to do QI. So I have to understand how I make time if I'm going to help the organisation.
Wow, very powerful. So you hear how visible changes at the leadership level, whether it's what you do, who you talk to, who your team is, are very powerful drivers. And then it's really understanding that chances are you're going to fail in the beginning. And how do you build up the will? I'll tell you my failure. Early in my career, I read about a new model of care, and I was very excited about it. And so I went to the head nurse of my unit, and I said, I think we can do this new model, and it will improve flow, and it will make care better and safer, and it will improve staff care. And it will require that the pediatricians move their patients from this brand new wing to an old part of the hospital. There was only a few pediatric patients anyway. And so the head nurse laughed at me. She said, yeah, right. So I said, no, we really need to do this. So she said, why don't you go talk to the hospital CEO? So I went down and talked to him. And he said, yeah, right. He said, if you can convince the pediatricians to move out of that wing, then I'll buy you the equipment. You can do whatever you want. So I went to the first pediatricians meeting, and they wouldn't even let me get the words out of my mouth saying, oh, I think we should move the pediatrics unit. And so then they said, you know, it's not going to happen. Every month for 6 months I went back, but the lesson I learned was that I needed to be multilingual. When you walk into a room and you're trying to persuade a whole group of people to change, people have different sources of meaning, and you've got to reach all of them. So I learned that what I would do is go to back to the pediatricians, and I would tell them a story. And I told them a patient's story that was very powerful. 1 or 2 of the pediatricians really resonated with what I was saying. And then I extrapolated, you know, there are X number of other patients who were just like this one. So I got into the hearts of some, and then I extrapolated to the total population, and then I talked about the human harm, and then I talked about the financial impact. And if you create that arc and you learn to be multilingual, it really helps because your idea is going to resonate with some but not all. So I think one of the ways to think about failure is to think you've got a very diverse audience here. Some people are going to need leaders to visibly change their calendar, and some are going to need people to go person to person. And each one of these people has given us a gift today to think about how do we really impact on change. Any other final thoughts that have come to you while we've been talking? Pass the mic back.
I think when you have those conversations is being able to make people feel safe to say, actually, we're not ready to start, and offer resources. So it's not all right to say, okay, that's okay, we'll come back. Let's say, what resources would you need to enable you to start?
So just, the psychological safety that Tom and Barbara were talking about, John and Barbara are talking about, is critical. And then the resources that you spoke about as well, just go ahead and do it, not understanding what resources are required is a huge impediment.
And I suppose don't assume that things are the same as when you last visited. I think it's always changing, and people's feelings about the situation change dramatically. We're going through some restructuring in the borough where I work, and there are a lot of feelings about. So that understanding that personal dimension is really so critical. I agree.
And I suppose I've been quite swayed by some of the things we've heard about in the last couple of days as well. So about extending the collaboration way past the borders of our own local geography, and there's much easier ways to do that. So we're going through quite a lot of change at the moment. It's given all of us lots of ideas about doing things at pace if we just embrace new ways of doing it. And that's quite tricky, because in an organisation with 4,000 or 5,000 clinicians working from all sorts of disciplines, they've all grown up with certain ways of being told how to work. I have lots of conversations with colleagues where the methodology in their mind doesn't quite fit with the way we want to improve. So there's a lot of work to be done there.
So we need to be sensitive to what everybody's going through, and the pace of change has never been this fast. So I think understanding the barriers that we face from these very honest conversations is really going to help you when you return to think differently about your approach to improvement and really increase your chances of success building on the failures that you may likely and you probably will experience along the way. So back to you, John and Barbara.
So we just want to sum up really some reflections that you cannot underestimate the importance of leadership, and you cannot underestimate the importance of helping people develop psychologically safe environments within which to work and learn. The mindset for teamwork is crucial. as is constancy of purpose and having meaningful data, and we are in such a better position now with the data in our organisation. It's really exciting. Methodology for improvement, just be constant in what you choose. And we've learned a huge amount from our service users and carers, and because we've been doing it in a co-produced way, we've got a much better set of standards that we would have had. And actually what this has done is it's created a level playing field for us all to learn together. And I think my personal reflections are being really aware of our own personal characteristics and what we bring in ourselves to work. And that it's not about being perfect, but it is about acknowledging some of the things that your strengths are in, and also what you need to be mindful of. Because in that way, it's much easier to have some of the conversations that we didn't have early on in the process. So we've got a quote to finish with, and this is also a personal one for me. It's one that one of our sons, who's had a series of quite significant health problems over the years, holds very close to him. So it's not about never falling down. It is about rising every time you fall.
So I was listening to the stories that you all gave, and each one of them resonated with me, and there was a couple that actually made me feel really uncomfortable. Those sensations that I had as a rheumatologist came back. I don't think any of you failed quite as spectacularly as I did, but thank you for your honesty. This has been a fabulous journey doing this presentation. It's been a real privilege working with these individuals in actually thinking through how improvement takes place at scale. And I've learned an awful lot, both personally and professionally, as we've done this. So I hope you've enjoyed the session, and I hope you take something home from it. So thank you very much for your time. Enjoy the next session, and safe travels home later.